Well, my name is Dan Carr, and it's my pleasure to introduce a world-famous and definitive speaker in today's topic. And we try to have people come and speak who are familiar with an area or authoritative in an area, but it's always a special pleasure when we get people who are people who made the area and defined the area and whose work has been quoted worldwide. Such a person is Professor Yoram Shir. He knows everybody in the pain community, having headed pain clinic in Israel at Hadassah Medical Center, having trained at Johns Hopkins, and having moved to Montreal about 10 years ago, where he heads a clinical pain program and holds the Edwards Chair in clinical pain research. So he has contributed in multiple areas, but in particular, given the interest of Tufts in nutrition, which ranges from our students up through a dean of our department in the nutritional aspects of quality of life. It's a special pleasure to welcome Professor Shir here and allow him to mingle with many of the current and former students and faculty of our program. So without further ado, I'm going to turn the podium over. As Professor Shir is making his way up, we owe a special thanks to the linkage performed through Beth Rosenberg, a personal friend of Professor Shir and his wife Raffaella, and a member of our Public Health and Community Medicine Department. So thank you very much, Professor Shir.
Thank you very much for the kind introduction. It's great to be here. Can you hear me? It's okay. So louder? Okay, I'll shout. And so the topic of the day is a bit strange if you consider my background. I'm an anesthesiologist. I started practicing pain, not knowing exactly what kind of things I'm going to do or what I'm faced with. And it's strange that an anesthesiologist suddenly is involved with pain medicine and especially with diet, but those are the facts, and I'll show you in a minute how it happened. But first, let me just tell you that after more than 20 years as a pain clinician, I'm not very proud with my achievements, even though I think I'm a much better physician or clinician today compared to where I've been a decade ago. I still think that our results are not good enough, and I think that our present efforts are not going to be more successful if we won't change a few things. And I'm a true believer that we should head or adopt other approaches like the effects of environment on pain, and maybe also prevention instead of just pain palliation. In any event, just to tell you that now everybody's talking about epigenetics, so I just want to tell you that when talking about chronic pain, I think that we know that there are many factors that could affect patients with chronic pain. It's not just the level of pain, and we know that things like previous exposure to painful stimuli, multiple socioeconomic conditions, and I'm not going into details here, childhood stress, for example, the weather. I could give you a talk right now on the weather, which is it's a fascinating topic, especially for me coming from Montreal this morning. It's freezing there. Here it's summer, it's like a Mediterranean city, so weather is an important thing. But no, my topic today is going to be diet. And the first question, why testing diets in pain models? Because this is where I started, so let me walk you through. It will take me 3 minutes to tell you the story. I think it's a funny story, an interesting one. So this is Hadassah Hospital in Jerusalem, where I've done my residency as an anesthesiologist. And when I've done my first steps as a basic scientist, researcher, I was lucky enough to join forces with Zev Zeltzer, who was my tutor and my mentor. And we, at that time, it was in the late 80s, we developed a new model that was pretty successful. And this model is called the partial sciatic nerve ligation model. In this model, we create a partial damage to the sciatic nerve in one side, and we create a neuropathic pain model that was novel at that time. And this pain model mimics a clinical pain condition that is called CRPS, or complex regional pain syndrome type 2. And I'm not going into details. I'll show you a picture in a minute. In any event, in our model, we could see many things that are similar both in humans, in our rats. For example, tactile allodynia, mechanical and heat hyperalgesia, et cetera, et cetera. And this is a picture of how it looks. This is a patient with causalgia of the left leg, and the clinicians among us know exactly how it looks like. It's a horrible pain condition. In many patients, it's cureless. There is nothing much we can do for these poor patients. And this is how it looks like. This is one rat after the surgery. You can see here that the rat keeps the injured paw on the cushion scrotum. We believe the rat cannot tell us I'm painful. That's why I'm calling along my talk, I'll call it hypernociception, because pain is perceptions that must be described. But anyway, we believe that this designates some kind of pain. And I couldn't avoid showing you this picture because this is one of my patients, and she gave me permission to show you a picture. She developed CRPS of the right hand. And when I asked her, what do you do when it hurts? She told me, I'm doing this. She puts it on the cushioned breast, and it reminded me so much of the picture of the rat. I showed her the rat picture. I asked her permission to put it just like the rat to show you that maybe our model has some clinical associations. In any event, this is just to show you one result of what we are showing. It's some kind of pain measurement. It doesn't matter now how we measure it. It's not the reason why we are here today, but it's some kind of threshold to touch or threshold to pain that involves touch. And the higher the threshold, the less sensitive the pain is, the rat is. And this is the baseline. As you can see, hours after the injury that we create, so the threshold goes down dramatically, and it continues for a long period of time. Surprisingly, it happens on both sides. So even the uninjured paw develops the same kind of pain. It's very interesting, but again, just to show you that it's a model that worked very well. And then maybe 4 or 5 years after we developed it and published it, and we were very proud of it, I came to Johns Hopkins. This is the main building of Johns Hopkins in Baltimore, and the pain group there wanted very much to use the pain models that we've developed, and I was really proud as a young researcher to be asked to do that. And everything was fine, but for the fact that even though I've done the surgery hundreds of times, I've done it there, and the rats showed the same thing, the same picture as I've shown you, there was no pain. Actually, rats were hypoesthetic. So the rats were even less sensitive to pain compared to baseline. And you can imagine that it's a bit embarrassing to come to one of the best groups in the world and not being able to show, this is your entrance card, and it doesn't work. So I worked for more than a year to try and find out. We changed a lot of, modified a lot of parameters or factors, and couldn't find the reason for that. And then one day, the boss there told me, okay, Yoram, what else? We all trust you, but what else? I don't know why. I said, listen, we didn't try to change diet. He said, what are you waiting for? Bring me the Israeli diet here. Let's see what's happening. So I brought the Israeli diet. I flew, we smuggled a sack of Israeli diet. You're not allowed to do it. So through the customs, my sister-in-law is a stewardess, so she helped me to do this. And we gave rats the Israeli diet. And this is what happened. So this is the American diet. This is the diet that I've been using for more than a year in Johns Hopkins. And this is again, some kind of pain measurement. Let's note, so the higher the pain measurement here, the more hypernociceptive, the more painful, if you like, the rat is. This is the American diet, and this is the Israeli diet, 4 times higher. Suddenly, we had the model again. So it opened our eyes. Suddenly, in 1992 or 3, I found out that diet could really change significantly pain behavior or pain-like behavior in rats. And this is how it all started. And then we started exploring things, and I found out things that I didn't have a clue about. So diet is an important factor in many ailments, not just in pain. And you have a list here. It's a partial list. We can bring many other examples, but this is just to show you what we're talking about. So all the way from cancer to rheumatic diseases and retinal diseases, et cetera, et cetera. And the first thing we have done, of course, was to try and compare the Israeli to American diets. Unfortunately, there are 2 unfortunate things. First, the manufacturers do not like to expose the exact component or what they put in the diets. You know the total amount. They're obliged to produce to give you diet that contains 15 or 20% of protein, this amount of fat, etc. But they don't tell you the exact composition or the exact sources of the diet. And so what we could find out more or less is, and you can have the comparison here between the American and Israeli diets, and you can see that they differ in some perspectives. And as you can see, and I'll talk about it a bit later because soy has become one of my favorite topics, you see that the American diet contains a lot of soy protein, more than 85%. This is the maximum information I could get from the manufacturer. The Israeli diet contains almost no soy. The second unfortunate thing is that before I was able to obtain another sample from the Israeli manufacturer and analyze it myself, they closed the doors and stopped manufacturing everything, and I couldn't have a sample to analyze. And so this is just, I have an approximation of what it contains. There are a few issues that we learned, and this is some kind of intermediate summary to tell you. So first, we know that red shows are standardized, as I said, for the total amount. But the manufacturer has no obligations for you, the customer, about the source. So if today the fish flour is cheaper, one will find fish flour in one's diet when given to rats or rodents. If tomorrow it's soy, it will be soy. So the total amount will be the same, but you don't know. It could differ between one batch to another. Now, if you read an article, every article that describes experiments in rodents will tell you a bit about the environmental conditions, so the 12 hours day-night cycle, and the water and diet ad libitum, etc. No one is telling you what kind of diet rats are having. But I think that part of this, that we said multiple times when we published our results, is that one should also mention what kind of diet his or her rats were consuming during the experiment. And we know that changes between labs could significantly change the results of behavioral tests in rodents. So this is one publication in 1999 where diet was not part of this, but we just know that changing labs could significantly change the results of behavioral results in rats, and it clearly applies to diets as well. So this is one message. When you do experiments with rats and you want to compare between labs, make sure that rats are consuming the same diets. So we started exploring things. We were at that time pretty naive. So these are some diets that we fed rats with. And again, I'm not going to burden you with what kind of diets they are. This is a diet that contains a lot of soy. I'll talk about it a bit later. And this is here, and this is again the response duration of the painful responses of rats. The higher response, the more painful the rats are, hypernociceptive the rats are. And as you can see, there is a major fourfold difference between the soy diet, in this case, it's one of the soy diets we use later on, and between this diet, which is pretty strange, because BC stands for white bread and cucumbers. And we decided to give it because we wanted to give a diet that is totally unbalanced, a diet that doesn't contain soy or other stuff. We got permission from the vet of the animal facilities to do it for a short period of time. As you can see, this is a very bad diet if we're talking about pain, because rats developed the most hypernociception was developed on this particular diet. So just to show you that diet has a significant effect, we're talking about the same strain, the same animal facilities, the same hand that has done the nerve injury, the PSL injury. So we entered, in my career, I entered the phase of diet for pain, and this is what I'm going to tell you today. So first, if you look at today in the internet, everybody can have a look and learn about it. I think it's one of the the most important things happening to patients, because patients now are coming to your clinic and they are not ignorant and you're not God. They know exactly like you. Many times they know better, and it's good that they learn. So this is what we can learn from the internet. Few things, for example, in this publication, diet can conquer pain within 21 days, which is not bad. Here is some advice on how to take care of sciatica, which is a common pain problem, people with herniated disc. So garlic milk is prepared in a certain way in helping you, and nutmeg is good. Now, I'm not so sure this is worse advice compared to what we're using. Looking at the success rate we are having with treating sciatic pain, maybe nutmeg and garlic should be used as well. I don't know, but this is what we can find. Another book, the chronic pain book. And again, I'm just showing you, I'm not just laughing or joking. I think that there's a lot behind it. The only problem is that we don't have enough scientific evidence. So earlier on, once we found it, I started talking with our patients. It's amazing what things can be learned when you know what questions to ask. So I give you here just 3 examples of real patients that I think it's the last 8 years or so I've seen them. So this woman is an Indian woman, of Indian origin. She's suffering from pain due to post-herpetic neuralgia. She had zona or shingles, and she has horrible neuropathic pain after the acute event. And as you know, in the traditional Indian cuisine, curry is one of the most important essence. And she found out by herself that whenever she is cooking with curry, her pain shoots to the roof. And she actually had to stop cooking with curry, and it was not well accepted by her family and her kids, I mean, because they expect to be. So she came to me, and she actually, I think in this case, she donated the information voluntarily. She told me, Dr. Curry is killing me. I cannot have curry at all. Help me. She didn't want me to help with the pain. She wanted me to help her, to enable her to cook with curry. The other woman, the other patient, is a patient with a benign pain in her breast, and she noticed that whenever she drank coffee, the pain was incredibly higher. Okay, again, diet and the effect of pain. And the other woman is a young woman with a post-traumatic neuropathic pain, in this case in the ankle. And she's one of the only patients that I decided to try soy diet, even though we don't have enough clinical evidence yet. I'll talk about it in a second. And I gave her a diet enriched with soy protein, and her pain went down significantly. So we learn from our patients, and we see interesting things. So what do we know? What does the literature tell us? Or is there any proof, scientific proof, that diet could really affect pain? So the answer is absolutely yes. And I'll just show you a bit. It's not all. There are many other things. So let's start with dietary fat. And we know that for acute pain, for example, a single high-fat, low-carbohydrate diet could decrease acute pain. And we know that the analgesic role of omega-3 polyunsaturated fatty acid in painful conditions, especially inflammatory conditions, rheumatic diseases, is well proven. I mean, there are multiple lines of evidence suggesting that this could be a partial remedy for these diseases. And when we look at the N3 PUFA just by themselves, there's a good evidence in patients with low back pain, patients with rheumatoid arthritis, and in patients with fibromyalgia. We ourselves have done some experiments with fat just to make sure, because again, we're so naive. I mention the word naive all the time because it's a learning curve. In the beginning, I thought that it's a protein, and I was sure that within 2 or 3 years, we'll find the source of protein that is analgesic in this case, and that it's going to be great. But later on, we found it's not true. And we started exploring also fat. So we're talking about fat. This is an experiment, again, in our rat model, the PSL model. Again, we measure hypernociception in rats. The higher the score here, the more painful the rat is. And you have here 5 types of fat. Again, it's artificial diet prepared especially for us. So we know exactly each component of the diet. It's well controlled, and it's the same diet that we've been using for years. And the only thing that has changed was the source of fat, not the percent fat, which was 5% in this case, just the source of fat. As you can see, there's a major difference between the corn and soy oils or fat. And in this case, we just use, go to the supermarket and you buy a bottle of and just add it to the emulsion of the food, compared to canola oil, or in this case, it's hemp, which is the cannabinoid oil. Canola oil, by the way, emerged as a very bad thing to rats in our pain experiments all over. It doesn't mean I'm not saying don't eat or don't use canola oil. I'm just saying that in our hands, canola oil was also associated with increased hypernociception in the rats that we tested. Mechanism that when you look at, this is convincing, fat could really affect pain, but what about the mechanism? So again, there is quite a significant and well substantiated scientific evidence showing multiple mechanisms of action to explain fatty analgesia. It's a modification of catecholamine neurotransmission, decreased inflammatory markers, modulation of TERP-V1 receptors, etc., etc. All these have been shown. So we are not talking about here just public opinions, etc. We're talking about things that are well substantiated. The same is more or less true for carbohydrates. So we know in experiments, both in rodents and in humans, that sweet analgesia in pups and adult rats has been well shown. We know that it decreases acute pain in human newborns undergoing painful stimuli. And we know that it could, to some extent, reduce inflammatory pain. And again, when we're talking about mechanism of carbohydrate analgesia, again, we have good evidence. For example, modulation of the endogenous opioid system, decreased level of inflammatory markers in our serum, and other mechanisms. The same is true for proteins. So just few examples showing that proteins by themselves could be analgesic or hyponociceptive. Years ago, we've done a study on diets rich with taurine, which is the most abundantly found amino acid in our brain. And we showed that it decreases pain in another model of chronic neuropathic pain in rats. We have shown, and I'll talk about it in a second, the soy protein decreases nociception in the PSL rats. And it has been shown to do the same thing in other models like bone cancer. And in humans, it has also been shown to be effective in people with osteoarthritis. And we know that lactoferrin, one of the major proteins in milk, is also decreases inflammatory pain both in rodents and in humans. Few other examples, just to tease you a little bit because of the ingestive analgesia. I like this term. So first, these beautiful pictures all belong to vegetations that have been associated with decreased pain in rodents or in humans. And each one of them we could talk about. I'm not going to talk a lot about them because of time constraints. I just want to mention one which I like a lot. This is what is called the sow thistle, this guy here. This is the picture of, and this could be found anywhere in the Mediterranean countries, in South America, etc. It's one of the most common vegetations you could find in side roads, etc. And so it seems that a lot of people, especially who enjoy traditional diets, use the leaves for the salads. And there are rumors that it's good for pain, inflammatory pain. Actually, there have been a couple of very good experiments in rodents showing that the leaves of this guy are really good in decreasing inflammatory pain. And so we have it here, we just don't use it often enough. The other thing I wanted to mention is alpha-lipoic acid, because it's one of the commonly used over-the-counter health product, if you like, that is being used both in North America and in Europe. And it's a very interesting compound, if you like. It's an organosulfur compound that's essential for some enzymatic mitochondrial processes. It's found in most of our diets, but especially in internal organs, in spinach and broccoli. And there have been some proven analgesic properties for alpha-lipoic acid, and you have the list here. But what's interesting is a study that I admit it's not maybe the best study in the world, but still it's interesting to look at it, because this study looked at a huge, relatively big number of patients. It was done in Germany. And they looked at people who have been on this compound for 4 or 5 years and stopped it and then switched to gabapentin. And the results were not good. And so in most people, pain aggravated after that, side effect profile was much worse, et cetera, et cetera. Again, this study has some flaws. I just want to mention it to you because, again, we are always, all the time, and I'll talk about it a bit later, we discuss all the time traditional medicine, what is accepted, pharmacology, well-accepted pharmacological interventions compared to the complementary alternative medicine or traditional medicine, unproven medicine, etc. So now to soy protein and fat analgesia. Early on, after we we had the first results on diet and pain in our model, we started exploring soy. And the reason is that soy protein is added to most commercial diets of rodents, and we know that the content varies between one diet to another. And we know that it contains ingredients with multiple biological effects or benefits. And so this is just a very simple example to show you what we have seen with our first experiments in soy. So again, what we have here is pain levels. The higher the response, the more painful the rat is. This is the commercial soy-deficient diet, the Israeli diet, as I showed you before. This is the commercial soy-rich diet, the American diet. And this is just an artificial diet we created with the whole protein content is soy, and it's the same protein content, by the way, like the other two diets, and you can see the difference here. And the same is true here for soy-deficient diets. So this is soy-based diet, and you can see no pain response. And we look at 3 different soy-deficient diets, and they are totally different from each other. The only thing that is common is that there is a much increased hypernociception with these diets. Now, when you see this, and as I said, I want to mention the word naive again, I was sure that we really have it now in our hands, and in 2 years we find it, everything, and we have a Nobel Prize because we're going to solve the chronic pain problem of the humankind. Well, it's not true, because it seems that just the soy protein itself, even the purest product you can buy in the market, it contains something like 85% protein. It's called isolated soy protein. Even when you do that, it contains so many in other ingredients, and so the hundreds of them. Just the number of phenolic acids that soy protein contains, it's amazing. So it's clear, and it could be a combination of some of them. It could be not just a single ingredient. But we found few things in various experiments we've done in the lab. So first, we found out that there is no association between the experimental site, testing methods, rat strain, vivarium, food vendor, caloric intake, and weight gain. So even when we change these things, still the effect of soy is strong enough to overcome all these other changes. One of the major findings we found was that if we supplement soy before the nerve injury and not just after it, the results are much better. So the preventive effect of soy is much more pronounced. We found that there could be some association with phytoestrogens, and we also find that it could be mediated through cytokine inhibition. I'll show you one picture. And we also found that there is a very significant synergism in the hyponociceptive effect of soy, protein, and fat. So just to show you some results, this is the result of our preventive use of soy. What you have here, this is the baseline response of naive rats. Again, it doesn't matter what we measure here. This is just the average response. And we are exposing rats here to soy-rich diet, and we stop the diet in certain time periods before surgery. So we stop it here 14 days before surgery. As you can see, a lot of pain response. We stop it 7 days, a lot of pain response. We stop it 1 day before surgery, still a lot of pain response. We stop it 14 hours before surgery, and there is still a pain response. However, when we continue with the soy diet until the time of surgery and stop it afterwards, no pain. So this is a very robust thing. We've done it twice because the results were too good to be true. I didn't believe it. We repeated it, and the results were the same. Phytoestrogens, again, a very big name on the shelf product of additional diets or supplements that people are taking. So estrogens by themselves were implicated as analgesic compounds, even though it's not so clear in rats and maybe in humans. Excuse me. And we know that phytoestrogens possess multiple biological activities, and just for you to know that phytoestrogens are not really weak estrogens. If something, they are mild anti-estrogens. They are receptor modifiers, and they are abundantly found in soy product and in plasma membrane of soy-fed rats. So we have done experiments on that, and I'm not going to show you, again, time constraint. I'm just going to show you the results. We found interesting result only in some, not all pain measurements that we had with rats, that phytoestrogens could protect against pain, but only in certain levels. When we were talking about very low doses or very high doses, where they didn't do anything, actually they were bad for the pain. And this could explain some of the controversy existing in the literature, because some scientists claim that phytoestrogens are not good for pain. Some say that it's good for pain. It could just be a dose response curve, and people didn't explore it before. And this is, I think, one of the, I want to impress you. I think this is one of the most impressive things I can show you. This experiment we've done a few years ago, where we have created the 9 possible combinations of three proteins, in this case soy protein, casein protein, the milk protein, and the albumin protein, with three kinds of fat or oil, soy, corn, and canola. And we created 9 different diets, and we fed rats, same hand, the same animal facilities with these 9 diets. There is a 200-fold difference in pain response between the groups that was fed on the soy compared to the groups here that were fed on albumin or on canola. 200-fold difference. And this is just by changing diets. We didn't change anything else. One last result, it's interesting result again. It's some preliminary data. There are many indications in the literature that could lead you to believe that the effect of diet in the injury nerve could be mediated through cytokines. In this case, we looked at TNF-alpha, and what we have done in these experiments, we selected just few rats that were fed on the good diet. In this case, it's soy protein and corn oil, and compared them to the fats fed on the bad diet, the albumin and the canola, albumin protein and canola oil. And we looked at TNF-alpha. Actually, the next picture will be better. Don't pay attention to this. This is where we do create the injury. But even with this slide, you can see this is immunohistochemistry. And what you can see is that there's a lot of TNF-alpha that you can see here. These are 3 different nerves from nerve-injured rats. And here, this is the bad diet, the canola, albumin canola. Here, this is the good diet, the soy corn diet, no TNF-alpha. And so we are almost convinced that partial mechanism could be explained by as anti-cytokine effect. Again, we have to explore it a little bit further. So the last part of my talk is, this is very nice, but it became clear, especially to me as a clinician, and I was urging to help my patients, that it's about time to leave the lab and to go to the clinic. And so I decided that's what we decided to do. So we stopped doing experiments in the lab because I cannot do all of these things, and decided, thought that we have enough to try and do human experiments. And I'm going to show you a few of our results, most of them failures, but anyway, we'll share it together. First, I like this picture because you see this happy family. I took it from the Time magazine, and I'm asking you whether or not you think it has a soy effect, because you see there are greens here. And the answer is that most probably they didn't consume soy, they ate peas. And the reason I'm saying it is that in the last decade, we have witnessed, especially in the US, a crusade against soy. And I want to make you laugh a little bit. This is some citations from the literature. So this is a picture, and this is a quotation from the literature. Will soy make my son gay? And this is not the only question that is being asked. You have a very nice list of questions. Does it boost brain power or dementia? Does it shrink penises? Should boys drink it, or will it turn them gays? Can soy affect menstruation? Tofu brings Alzheimer. All these are taken from the literature, I mean, from the internet, so you can find it yourself. And I think that the top is this citation by this gentleman who you have the affiliation here. Soy, he is not a physician, he's not a scientist. Soy is feminizing and commonly leads to a decrease in the size of the penis, sexual confusion, and homosexuality. By the way, if you know, there were great responses in the internet to people asking him questions about how exactly he knows about the size of penises on people, etc. But this is not the issue now. This is official citation. That's why most of the medical, not social, blame for today's rise in homosexuality must fall upon the rise in soy formula and other soy products. So what can I say? In any event, we have done a pilot study in patients with neuropathic pain to see whether or not they can handle major manipulation of the diet in trying to enrich the diet with soy. So it was 6 weeks experiment, patients with long-standing neuropathic pain. We switched at least 50% of the daily protein and fat to soy products. The results, we have never published it, was a pilot study. The results were that if you look at the average pain response, it was not significant. However, there are 4 patients from this group that almost recovered completely, and I'll tell you a bit about one of them if time allows at the end of this talk. The most important thing, however, in this experiment was that our primary outcome was not pain. It was the size of tactile allodynia. Now, allodynia is one of the major symptoms or signs in people with neuropathic pain. It means that it's a painful response or feeling of pain to a stimulus that is normally non-painful. And so if you measure the size of the allodynic area before intervention and after, and if it shrank, you could say that you've done something. So we measured area of tactile allodynia, and it hasn't reached significance, but we've seen major changes. You can see it almost, it shrank to almost 50%. The truth is there was one patient in this group that in the end of the study told us my pain has not changed a bit. When I measured his allodynic area, it shrank from something like 94 square centimeters to 0. His allodynia has completely gone. Even though, because we know that neuropathic pain is multidimensional, even though his pain per definition didn't change, his allodynia has gone. But again, it was a pilot study, and as you can see, it hasn't reached significance. The most important study, I think, that I've tried to do so far in my career was to follow the results we had in rats with a preventive soy, showing the good results we've shown with soy given before injury in rats. We wanted to do the same thing in humans to see whether or not we could prevent chronic pain or chronic neuropathic pain. Now, most humans are not familiar or cannot tell when they're going to be injured. And so the only things that we can do is develop some kind of a ambulatory model. And the model is post-surgical pain. Unfortunately, we know a lot of surgeries are being done. We know that neuropathic pain or pain in general after surgery, chronic pain, is pretty common. And we have decided to adopt the model of women with breast cancer undergoing breast cancer surgery and lymph node dissection. We know, it depends on the literature, we know that up to 30 or 40% of these women will report chronic pain after the surgery. Fortunately, not most of them, it's not excruciating pain, but pain it is. So we decided to adopt this model, and we try to recruit women to do this, giving them in double-blind prospective study either soy protein or milk protein for 2 weeks before surgery. We couldn't do it for a longer period of time because surgery must have been done early on after diagnosis. Surprisingly, it was nicely supported by the National Center for Complementary and Alternative Medicine and the NIH. And we had so many limitations and so many restrictions by Health Canada and by others that the exclusion criteria were such that out of the first 94 women that we screened and wanted to recruit, we could recruit only 5. We worked for 4 years, and a few months ago, we prematurely terminated the study without having any results. It's a sad story, but this is the most we could do. We are not the only ones. And so colleagues from Johns Hopkins, where I worked, tried to do the same thing. Again, they were supported also by the NIH, tried to develop more or less the same kind of study in another ambulatory pain model, which is after thoracotomy, patients who are having lung surgery. We know that it's also a very, it's a human model where we see a lot of chronic neuropathic pain after the injury. They failed as well. They closed the study even before starting it, again because of major restrictions by many authorities and inability to recruit patients. So there's nothing much I can tell you. I can tell you just one thing. It's much easier to do studies where you compare 2 pills compared to study where you manipulate diets. One other study that was finished, not in neuropathic pain, in fibromyalgia, and it's a good study, didn't show any effect to the soy. I'm not surprised because I'm not a believer in one bullet kills all. And we are looking at soy with neuropathic or nerve injury model. In this case, it's fibromyalgia, which is a different type of pain model, just to show you that soy is not a miracle drug. The last piece of evidence or of interest I want to tell you is this story. Yes, we have 5 minutes more. And so one day I'm getting a call from a lady I've never heard before from Australia. And this lady is not a physician, she's not a nurse. Her mother, I found out from her, suffered from what is called trigeminal neuralgia. It's a neuropathic pain because that is due to damage or injury to the 5th cranial nerve. It's one of the most severe and devastating pain conditions known to humankind. And so her mother, and many times there is no cure for that. So she saw her mother suffering. She saw that no one can help her. She created, actually, she organized the first Trigeminal Neuralgia Patients Association of Australia. I think there are more than 3,000 people now in this association. And she started exploring. It was a full-time job to explore literature, to speak with people, experts in the field, whether or not they can give her advice. And she found one of our soy studies in animals. And she, without asking anyone, decided to recommend to some people there in this group to start having soy milk, okay, to drink soy milk. And she called me after she saw the results. So this is a report without the name. It's a word-to-word report by one of the patients with trigeminal neuralgia. And this is a diary because she insisted. She was really good. I met her. It's a feeling diary. So I'm not going to burden you with everything, but if you can have a look here and see what this patient, what he's saying. This week, I have been pain-free. Pain-free for someone with trigeminal neuralgia is something that's beyond imagination. Third painless week, etc., etc. So the results were good. She's coming and said, listen, Dr. Shir, please help me. I want to organize some kind of a mission here to give soy to our patient. I was ecstatic. I thought it's a great idea, but found out earlier on that it's very difficult to do because she didn't want, it must go through some kind of a center, ethics, some guidelines. You cannot just give advice through the internet and give them this and that. She refused. She said she doesn't have time to do this. I asked her permission. And right now, we are in the middle of doing a study, actually, in looking at soy protein-rich diet for treating two types of neuropathic pain. One is a trigeminal neuralgia, and so far we recruited, I think, 5 patients finished the study. By the way, we are doing in a bit of unusual technique. It's called N-of-1 study, which is good, I think, for pain patients, where the same patient switches from the placebo, the control, to the thing or drug or compound that you're experimenting, and they're doing it time and again. The patient and you are blinded to this, and then when it's finished, you can have a look at a single patient. Each patient is his or her study, and then you can see the results. And so we are in the middle of doing it. I'm not sure about the results yet. Well, within, I believe, 3 or 4 months, we know about it. The other models that we will be starting soon, most probably, is another pain neuropathic model, which is called vulvular vestibulitis or provoked vestibulodynia, which is a devastating pain problem, especially in young women, where they don't have spontaneous pain in the vagina, but whenever they're being touched there, it's extremely painful. And again, no cure, no remedy, and we want to see what's happening, what's happening with this population if they're going to consume a soy-rich diet. Again, what we compare is soy versus milk protein, and we try to change at least, to switch at least 50% of the daily protein consumption to the soy product. I would like to summarize and just tell you that there are major barriers for exploring and adopting dietary analgesia. Maybe before that, just one minute to tell you about one patient, and then I'll just go over there. This is my last slide. One of the patients that we had in the pilot study that I told you, where we've done the soy experiments, was a woman after a compound fracture of the ankle, and she had neuropathic pain all the way from the ankle to the knee. And we know that in this patient, many times the pain is extradermatomal. It doesn't follow the regular dermatomes, and the pain was horrible. Even though the injury was there, the pain was all the way up to here. She was a pastry chef, among other things, and she did with the soys that we gave her all kinds of things, cookies and cakes. And within 3 weeks, after we started the soy, her pain shrank and just concentrated on the area of just the ankle. And it was an unbelievable success. Actually, later on, the allodynia, the size of allodynia shrank all the way. It was, as I said, all the leg from the knee down. It shrank to an area this size on the plantar surface of the foot. And she continued with the soy diet actually up to these days. She continues now for, I think, 6 or 7 years. She stopped it every once in a while because she felt she's gaining weight because soy is also calories. But This is one of the greatest success stories that I've seen. Again, it's not even an N of 1 study. It could be anecdotal, it could be placebo, but it's working. I've seen it working in a few other people that I tried. When I tried everything, nothing helped. I sat with them, explained to them that I have no scientific background, but since it's so easy, maybe they try it. I've seen anecdotal cases. I'm not going to tell you about it. It's not real science. And I don't think I have the right to do it, just like this before we have more proof. But I think that there is something there with soy. So just to summarize, barriers, the dominance of the Western medicine in medical education, the disrespect in general to complementary and alternative medicine as part of clinical practice, McGill research in the area of evidence-based medicine, much more difficult to explore and practice. It's really difficult. It's not easy to try and do these experiments. And it's not appealing enough to investments. I mean, you cannot really have a patent on this, vegetation I showed you that grows, on the side roads in Italy. Pharma companies will not support it. Governments will not support it. So it's difficult. This is it. Thank you very much.
So thank you, first of all, very much for an authentic and very high integrity presentation showing the evidence and the lack of evidence or difficulty in acquiring evidence. At this point, we can open the questions to the audience, if there are any questions. Perfect. Let me pass around the microphone.
Thanks, Dan, and thank you for a really enlightening seminar. I'm wondering if you have rodent studies and then human studies. Are there no other animal models of animals maybe a little bit more like humans that might offer some opportunities for study?
I'm not familiar with any study, for example, in primates. No, I am not familiar with any diet study in primates looking at pain or nociception. No, not a single one to my knowledge.
Does it seem like a avenue worth exploring to you?
To me, not, because one of the reasons I left the lab is that I couldn't go on killing animals. So I will not, personally, I will not do any test experiments in primates. I think that it makes sense, yes.
Thank you.
You didn't mention taste in any of these results. I understand if you feed rats a saccharin solution, that produces analgesia. So does soy taste different?
So you're right, I didn't mention taste. We have looked at this, and we know that the hedonic pleasure of eating food could affect how much you eat. And the question is whether a tasty food will be more analgesic or more hyponociceptive compared to non-analgesic food. So we have, I can give you a good answer, because rats that consumed the white bread and cucumbers hated this diet. And they are the only group that lost weight. They didn't like it. But the results, as you can see, were more or less like in any other groups. We have tried some other diets where the carbohydrate concentration was higher, assuming that sweet taste, etc., and we didn't see difference. So I can give you partial answer, but I cannot guarantee that the hedonic pleasure doesn't play some role in what we're seeing.
Thank you. Brilliant story. Thank you very much. I'm interested in mechanisms, and your TNF data were really intriguing. Obviously, the question arises whether this is sort of causal or a bystander effect. Do you know of anybody who's tried experiments where soy-fed animals were spiked with TNF to see if the pain comes back, or the opposite, where in a regular diet animal, soluble antibodies or so against TNF were given to see if the pain goes away?
So to my knowledge, we are the only group that has ever tried to do these experiments, cytokines, diet versus cytokines. I can tell you one other thing. Nerve injury, one of the first things we see is the recruitment of macrophages into the injured nerve. And so we learned that the number of macrophages recruited to the site of injury hasn't changed at all with the soy diet. However, they were just empty. They didn't contain the TNF-alpha. And so actually it wasn't, I didn't want to spend more time on that, but this is what we have seen. We've seen it, by the way, with interleukin-6 as well, and we've seen it with one or two other cytokines. But again, it's a partial story only. I'm not going into details right now. It has been published in abstract forms, but we don't have official publication of that. So these are the pictures, but we haven't published it yet, and no other group has looked at it.
I have a couple of obvious questions. The first is, if a clinician should be viewing this talk and want to introduce soy into the diet of a patient on an anecdotal basis, we have soy milk, I guess tofu contains soy. What formulation of soy would be a practical one to introduce?
So the first question is whether or not soy is safe. And the discussions we had with Health Canada for 2 years was whether or not we're allowed to give soy to women with breast cancer, because they claimed that phytoestrogens could be harmful. There was a publication in JAMA a couple of years ago looking at 4,400 women diagnosed with breast cancer in China and operated for that. And they looked at the recurrency of the disease and mortality, and they associated it or correlated it with soy consumption. What they've shown that women consuming more than 20 or 25 grams of soy protein a day, the mortality rate decreased by 30% and the recurrence rate decreased by 32%. We also know that soy consumption of soy protein in the traditionally soy eating communities in the Far East, we know that the prevalence of breast cancer and prostatic cancer is significantly lower compared to the West. We also know that people moving to the West from there within one generation, they equalize the prevalence in the West. So we have good indicators that we're talking about cancer, for example, soy is beneficial in something. Both probably in premenopause and postmenopause women. So the first question of whether or not soy is healthy, I think as long as we are not consuming phytoestrogens above a certain amount, again, it depends, 50 milligrams a day, 100 milligrams a day, but if you don't go beyond that, I think it's really safe. And so I think that one is allowed to recommend it as a non-scientific intervention. What I'm telling the few patients that I've done it is try and consume more than 20 grams of soy protein a day. Now, there is even though soy protein has been tried for its other properties, for example, lowering triglycerides and cholesterol, and there have been even a review article on the New England a few years ago on the use of soy. Even in the New England review, there is no dose response curve, so nobody knows how much to give. So it's a matter of educated guess. What I'm telling my patient is to take more than 20 grams, not more than 30 grams of soy protein a day. So if you want to switch just to soy milk, glass of soy milk is on average 7 grams of protein per glass. So 2 or 3 glasses of cups of soy milk a day.
So someone could take soy milk, or they could go to a health food store and buy the soy protein as a dry product.
Yes. Now, what I'm telling you now is totally not substantiated. I do have the feeling that this isolated soy protein, the powder that you buy in soy food, is different from the soy on the shelf. And I am not sure that the powder is better compared to the shelf. And actually this week we had a meeting, and we might try to switch to the shelf products to see what's happening. But this is just a gut feeling, not more than that.
When you say shelf product, do you mean
soy milk, yogurt, tofu, etc., etc.?
Further questions? Well, we thank you very much for the up-to-the-minute story on a fascinating topic, and a nod again to Beth for the facilitating role.